So hello, my name is Jasmine Bishop. I'm the Director of Telehealth for MaineHealth. And today I'm speaking with Iris Berman, the Vice President of Telehealth Services at Northwell Health. Iris is a registered nurse by trade, having provided clinical care for over 30 years at Glen Cove Hospital, and now leads the telehealth services at Northwell. How are you, Iris? Nice to see you.
I'm doing very well, thank you. How are you?
I am great. Well, this has been quite an experience, the whole COVID-19 pandemic for everyone, but particularly for the telehealth world. I'd love to talk to you more about your experience leading a telehealth program at a very centrally hit location. Northwell Health is located in New York City and around that region. But first, before we dive into that, I'd love to get a better sense of who you are and how you came to the role that you're in. So I read that you've known you wanted to be a nurse since you were 6 years old. What did that look like for you?
I was the kid that would bring everybody into my mother's kitchen every time they got to cut and scrape and apply some kind of Bullwinkle or cartoon Band-Aid. And it started that way, but I did have a family history. I had a couple of aunts that were during World War II nurses, a nurse midwife, unfortunately during the Holocaust, who continued to provide care in one of the camps. So the stories that she told inspired me a great deal as a child, and it was just never a doubt for me that I would do something in nursing. And it has exploded in a career that I could never have imagined from then. What I'm doing now, if you had asked me 30 years ago, I would not have been able to foresee this. I'm sure none of us would have, but certainly the degree to which I've been able to have the pleasure of using my nursing experience to help to develop the telehealth programs in Northwell has been a really exciting and unpredicted path that I've been able to take. I'm really fortunate.
Yeah, and I'd love to hear more about how does your clinical experience help you in your telehealth role?
Well, so the first way that this started out was back in the day. So let's say about 7.5 years ago, we had started off with just a tele-ICU. And we had small pieces of telehealth, like a few sites that had telestroke on a platform that the neurologist had started. And then come tele-ICU, and I applied for the job as ops director specifically for the tele-ICU. And I started realizing as I was running that program that there were overlaps in care. A lot of these patients that were receiving other telehealth facets of care were becoming siloed, and there was a connection, right? A lot of these people would wind up in the ICU. And then I started thinking about the continuum of care. And it wasn't just me, it was the people that hired me into that position as well. Dr. Dorfler in particular had the same, we realized we had the same vision, which is we need to build this out. We need to do more with this. So we started on the acute care side, really expanding on the technology we had gotten involved with just for tele-ICU, which at the time was Philips eICU program and still is. And we grew that program, but then we started realizing we had the capability to bring in other specialties. So we did our own workflows with the hardware. And one of the things I had done in my background on my way into this role was become a nurse educator, a nurse manager, some hospital administrative work as a supervisor. And all of that gave me experience to understand the processes in a hospital and the continuum of care for our patients. Because I was involved in discharge planning, I was involved in admissions, and I could see that there were connections to be made. And we all believe that telehealth could help connect the dots for certain populations, particularly, and believe it or not, I mean, we talk about rural and underserved areas. Well, there's underserved areas even when you're in the urban areas or in the suburban areas. I mean, we have smaller community hospitals where specialists find it harder to get out to those hospitals. We started having our aha moments. We can bring in these specialties based on the technology we brought in for tele-ICU. So that's how it started. Fast forward a couple of more years, and we're saying, okay, the market has now started to expand, and we're starting to see movement out on the consumer side, right, the direct to consumer. And doesn't it make sense that we should now be pushing in that direction as well to give this as one other resource for patients who were having difficulty with access whether it be confinements of jobs, physical confinements, or what have you. So we started to explore that. As this was growing, the team started to grow. We realized we needed program managers. We realized we needed, advocacy in terms of medical directors and expanding our staff beyond the acute care world. Brought in Patrick McCarthy, who I think you'll meet in other meetings in a few weeks, but he's our AVP, and he helped us to build out our direct-to-consumer platform. And I mean, the story goes from there. As you know, COVID came in, so things just exploded.
Wow, that is quite the journey. You mentioned
it could go on longer, but we wouldn't have time for anything else.
No, it's so exciting to think about all of the different patient settings that technology can be used to improve access and the opportunity for our care teams to work together more efficiently using technology. So thinking about that specifically, you mentioned hardware workflows. I know for us up in Maine, we are expanding a lot of our specialty programs to our rural hospitals. And that's one of the hardest challenges. People often think that telehealth just needs the technology. Well, we know if that was the case, we'd have this type of boom 20 years ago when video technology first really started getting pretty good. How do you approach developing workflows that work for your care teams?
Well, the first thing is we have to have the content and the experts at the table, but also you need the end users, the people that are going to end up using the technology. No decision should be made without the nurses, the doctors that are going to sit there. And more recently, we've actually said, you know what, it might not be a bad idea to bring some patient advocates in too, to say, how does this feel to you? Because what we think is acceptable, because we're dealing with it all the time, may not be quite the same feeling for our patients. So we do a lot of surveys and feedback as we expand our programs, and we continue to learn and add and modify. While there's a template, if you will, for the initial workflows, particularly in hospitals, every hospital has its own nuance in terms of its staffing, its capability, whether they're unionized, non-unionized. Northwell is 23 hospitals, some unionized, some not, some urban, some suburban. One is almost a rural area or a much less populated area. The degree to which they actually need those ancillary services is different. The services they need are different. So you have to customize based on their needs and the workflows. The hardware itself, we're trying to standardize as much as possible. One flavor of, say, mobile carts in our emergency room. And we're looking now at a little bit more mobile work with tablets, but again, standardizing the way they get used so that we have some quality control over the outcomes of a telehealth encounter.
That certainly resonates with me. So I'm sure that can resonate or will resonate with some of our audience dealing with exactly that same issue of how deeply can we standardize while also appropriately addressing the nuances in clinical care between specialties.
Right.
And that is the question. And one of the hypotheses I think that was out there in our field prior to the pandemic was this idea that we might be technologically ready for a one-size-fits-all vendor or hardware solution where we could pick one cart or software and it would work for all of our patient settings. Do you think that that's a viable idea? And how are you addressing other care settings in terms of your hardware and software solutions?
It is only viable in my mind in the Northwell or a health system owned facility. Now you're starting to talk about, and I'm sure you've heard or been involved in some of these discussions yourself, hospital at home. You're not going to be able to control quite as much in terms of a patient's own access, but you can control the devices that are brought into the home and any of the remote patient monitoring, standardizing those things so that you have a single central intake area that there's consistent data flowing from. So I think it's going to be a hybrid. From a provider standpoint, we've tried And we've been pretty successful. There's always people that say, well, I'm just going to use my own computer, or I'm going to try to use my own phone. People will always figure out a workaround, and sometimes it might be a necessary workaround. Let's be fair about this. But I think the more you can standardize, the better you can evaluate those variables. Because every time you change a device, particularly on the provider side, and there's a problem with an encounter, trying to get to the bottom of it to some quality control becomes more difficult. So I think a lot of it is educating the users, both the providers and the patients, about the protocols around telehealth and what your expectations are for what you get out of that. And the truth of the matter is, like I said, the provider we can control for, but the patient use, we have to be prepared for the fact that it has to be a device that they can afford, or we have to be prepared to supply that device to them. And we have done a little bit of both, depending on the populations we're serving, and try to be prepared for both. A big piece of this, which we're still evolving, is we need really good support teams for the patients and support teams for the providers, and it has to be timely. And that is not an easy feat. That requires, pretty much 24/7 resource. It's expensive. And so you have to think about, what does that look like for your organization and for your patient population? In addition, if you're multicultural like we are, there's translation services which have to not just translate into the actual telehealth encounters, but also your support structure. How are you going to support those patients? We just recently encountered this with our Hispanic speaking population, plus being elderly, trying to talk them through how to do a telehealth encounter when they didn't necessarily have a family member there that could help them, a younger family member that could talk them through it. We brought in our interpretation services, but it points out still that there might be a need for some boots on the ground and some community outreach to get people ready for that next level. It's also something I'm bringing up. We have a panel in New York. It was the Reimagine New York, and that document just was released this past week, of all of the suggestions for what needs to happen in healthcare for telehealth as part of that, and technology. It also covers things like education, so there's some similarities across that because it's just device use. But we did agree in a smaller group that's looking at education and telehealth that we need to think about the fact that to be ready for the virtual world, you still need to have the boots on the ground training, the hands-on training. For some people, there's different kinds of learning that happen, and we need to be able to provide it in many different forms, not a single form.
So it seems like starting a telehealth program is pretty easy, right?
Oh, sure. Piece of cake. It's funny. Like I said, it grew and it had arms. And if you looked at the diagrams of the growth, and I know, we talked about going into this a little bit. I mean, starting off with one thing and building out tele-ICU, once we figured it out and all the variables around it, it was really about being technologically ready in each facility we put it in. And you knew what those pieces were. You start pushing out into the ambulatory world and into the acute care world, and the timing and the facets and all of those variables I mentioned. It is a big nut to crack. And it's not for the faint of heart. I think, though, that there's the way we either build on our own when we're larger health systems, or systems that have to build on our own just because of our expanse, not necessarily because of size and numbers, but because of our geographical coverage. We have to figure out how to build on our own. Then you have your single standalones that maybe need to do what we are commonly calling plug and play, which are your organizations that give you everything from soup to nuts and you white label. And maybe you're not using all your resources. We're fortunate in Northwell that from a provider side, we have all of the different specialties that we can provide to other locations, even beyond our health system if necessary, and have where other people might want to purchase those services. So there's also the arms of, the outreach you do beyond your own system of care, and what you need to do internally. And are you going to build for both? There's a lot of decisions to be made. And some of them sort of happened organically. And then COVID came along and really expedited that, because we thought we had a 3 to 5 year plan to get everything up and running. And the next thing you knew, in 6 weeks, we were from a couple of hundred providers and a couple of hundred telehealth encounters out in the community and providers' offices, we suddenly were in the 5,000 a day range or more. So, and going from a couple of hundred providers to something like 7,000 providers.
Wow.
In 6 weeks.
Let's dive into that a little bit more. I understand back in 2019, Northwell had over 30 programs for direct to consumer, including tobacco cessation support, telegenetics, neurology, your convening clinic, and then everything that we've already kind of touched on in the hospital setting. How did that change from the end of 2019 to March 2020? What does that look like for
you? We have a project intake, and we would put out there and make announcements at different meetings. If you're interested in adding telehealth to your practice or your specialty, reach out to us and we'll help you to stand that up. And we had already had our contract with our direct to consumer, which is Amwell. And we were getting people one by one, practices or groups. We would try to look for symbiosis in the groups. COVID comes along, and now and because of that, now every practice and every specialty has the capability to provide a telehealth visit. Now, in the beginning of COVID, it was on the fly, just what we call quick connect. We're now integrated, which was no easy task and done in record time, I have to say, taking all of these different, because we did it specialty by specialty so that there'd be a uniform, we talked about this earlier, a uniform way of doing that scheduling and integrating backward into our existing legacy systems. And then we built out our digital portal patients, which we were in the midst of planning. And now what would have taken 3 years, we've done in less than a year. And when I say we, it's a collective we. We have amazing groups in what we call DPX, which is a digital patient experience. Really, I like to say digital patient and provider experience that allows the patient now to go in and create their profiles and really do everything like one-stop shopping in that portal. That was no easy task. It's continuing to evolve, but that is now the way that all appointments can be run. We can also do them on the fly. But this is a way for patients to have contact within the health system and reach out and even go to patient access services if they're saying, hey, I'm looking for a dermatologist. They can go in, they can say, yes, I want a digital encounter. I want to have a telehealth visit. And our patient access service is also integrated into the back end of our digital portal. So it's become a much more holistic approach from where we were even at the height of COVID. It's given us the momentum we needed to continue to build. And there was the aha moment that we really needed to move this along. We couldn't really take our time anymore with getting there.
Absolutely. And I think that experience is certainly mirrored among our colleagues that I've spoken with across the nation, seeing around a 2,000% increase in telehealth visit utilization. Certainly that was our experience up here in Maine.
Yeah.
How does it look today? So we're a year from the pandemic, and I understand you've had some opportunities to optimize these workflows and clean up some of the technology that's in use. But in terms of your utilization, are you staying pretty steady, or have you seen dips in certain specialties?
Well, we're definitely having dips, especially in those types of visits where you had incidentals, like people who need to come in for their EKGs, their sonograms, that kind of thing. But I would say that we've leveled off to about 10 to 15% of our visits being telehealth right now. I know the industry standard that people are predicting is 20%. It's really going to depend on your reimbursement landscape, I think. And it is a concern, but I think it's here to stay. It's certainly going to be here in terms of bundle payment type programs or joint programs for the follow-up visits. That's easy. And there's a lot of other programs where it makes good sense. A lot of it depends on your carriers, your payers, and how we handle that going forward. I do think there's concern for it to drop a bit more until we figure out what that landscape is really going to look like. And it's an opportunity now for us to advocate. That goes back to what the biggest questions have been from HHS and CMS are around, they talk about fraud and abuse, which I think we finally have them saying, okay, we understand fraud and abuse. If something happens in telehealth or it happens on the phone or it happens in person, it's not the modality, it's the person that is the problem. And telehealth doesn't lend itself to any more fraud and abuse than any other modality of delivering care. If somebody has access to a vulnerable person or population and they want to take advantage of them, they're going to become innovative with whatever they can. And years before there was telehealth, it was the phone, and before the phone, it might have been door to door, who knows, or a mail order. It could have been anything. So I think the MedPACs of the world have finally said, okay, we'll accept that to an extent, but we now need quality outcome data. Does it impact? Does it improve? There was a concern about increased utilization. In some cases, it may increase utilization, but the bottom line is, what's the long-term outcome? By getting care earlier, can we prove that we can avoid more costly care later? And so this is a request also, is that we all need to look at our outcomes in a uniform way so that we can provide that information to our representatives to provide back to CMS and HHS, whatever state you're in, to say, no, look, this is what it does, particularly in the populations they cover. The other fear, of course, is, whatever CMS decides to do, private payers will follow. So, we want it to be evidence-based, like we do everything else in medicine, evidence-based decision-making around what should or shouldn't be covered, and look at quality and accessibility, which we talk a lot about, that digital divide. It both eliminated some walls and created others, which is something we realized during COVID. And it's another piece that we need to get a good handle on if we're to advocate for telehealth for all.
Absolutely. And I think you've covered some really important topics there that all of us in the field are anxiously awaiting word on. And that is the big catalyst for the increase in utilization at the onset of the pandemic was the change in policies, and they're not permanent changes. So just for our audience, just quickly reviewing what some of those key items were, at least the way I see it, and please feel free to add in others, but the Medicare payment changes to patients' homes, to urban settings for additional provider types, not just physicians and NPs, but also our allied professionals like our speech therapists and LCSWs, additional groups of codes that we can now bill for, letting folks work at the top of their license, among other pieces of it's not even full legislation yet, but waivers that we can leverage during the pandemic. And you mentioned MedPAC. And so for those that aren't familiar with MedPAC, I'll just give a quick acknowledgement that the MedPAC is our Medicare Payment Advisory Commission. And we saw in recent weeks in recommendation that before they'll give any kind of long-term expansion to these waivers, that they'll let them maybe stick around for a couple years past the public health emergency expiring for the purpose of studying the actual clinical and financial impact. I understand you're a board member on CTEL. Can you talk a little bit more about who CTEL is, what that experience looks like, and how you can impact some of these decisions, and how you are seeing the recommendations from MedPAC?
So I sit on the advisory board for CTEL. There are a group of us that different areas with them to visit, to speak with our representatives, or to deliver information that the leadership in CTEL will then deliver either to the White House, to HHS, or CMS. We've been primarily focused on reimbursement and parity, which, here in New York, we have coverage parity, but not payment parity prior to the PHE. And it doesn't appear that we're going to move anywhere with payment parity anytime soon. Right now, I think if we can just get parity squared away universally and look at some type of payment equality, if you will, for the visits, we need to be visiting that as well, because the truth of the matter is, if a provider still has to keep the lights on in their office, we're trying to make them understand there are still qualified providers that have an education that still have office managers to an extent, whether it's virtual or not. There's a cost to running a healthcare clinic, a practice, a hospital. So why would reimbursement be significantly less for a service that is a quality service when applied appropriately? So the big request and what MedPAC has looked at, which we're thankful and hopeful that they've extended the period of time to examine that. And I believe also CMS added another 60 codes on that they expect to be at least permanent. And I'm still trying to analyze and understand them because language is tricky. And we have a revenue cycle group that goes through that with us. And there's a large group in CTEL that examines this, well, legal people trying to understand the legalese behind the wording in some of this coverage, because it's not always straightforward. And that makes it harder for us to track data and accurately get information to CMS to make those decisions. And so what we're advocating for is looking at a data dictionary, which CTEL has been working on with a group that is looking to do data analytics. And they're asking in turn for data from a number of nonprofits and some support, because it is a nonprofit group, to do a deeper dive. The belief that they're seeing already is that there is, in fact, cost savings. It does avoid more expensive care, but we need a larger data pool to be able to prove that. And so there's a good amount of work being done, and they do a lot of research into data related to that care, both on the ambulatory and the acute care side. There's a lot more that they're doing. They've been on Capitol Hill. We've been in the White House. We've met with representatives from Congress and the Senate to educate about telehealth. The other thing we can all do is invite our representatives to come to our sites to see what it is we really do on the acute care side, particularly to see what impact we have. Tele-ICU still continues to be looking for reimbursement for that type of care, and there's some consideration there, but it's been deliberated for quite a while now, and there we have plenty of data about our impact and our ability to impact length of stay and acuity and outcomes. So we continue on that path with CTEL, and then again on the state level, we all can be involved with our own representatives.
That's such a fantastic idea to do some more homegrown advocacy locally, while these groups get together to impact it at the national level. Now, you've mentioned what needs to change in order for telehealth to continue to be utilized and leveraged long-term in terms of our reimbursement landscape and the policy landscape. But what about the user experience? I know for me, I'm frequently asked how to explain the skyrocket in telehealth utilization at the start of the pandemic. And even after we cited the leniencies that we've already talked about here today of restrictive leniencies and restrictive policies and favorable telehealth reimbursement waivers, there's still folks that feel like there's a lingering question if our patients really want telehealth once they're no longer fearful of catching COVID. Do you see telehealth as a COVID gimmick or something that's has value long term?
Well, I got to be honest. I think there is a particular population that will always want it. I do think, for some, again, going back to the finances around it, it will come down to the dollars and cents. If they're not going to get covered for it, they're going to go to the office, even if it's inconvenient for them, just because they can't afford to pay for it any other way. On the other hand, there's a number of payers that are incorporating it even before COVID, adding it into their coverage. So they must be having their aha moments. United Healthcare comes to mind. Some of the Empire plans come to mind, where they're offering their own telehealth programs to their covered population. I give you an example of my son, who well before COVID had, worked out of the house at times because this was already a trend. COVID pushed it to the end where more and more people were working out of the house. But one little kid at home gets sick and he's got to work. But now, what is he supposed to do? Leave work leave work, leave home, take the kid to the pediatrician, then go pick up a prescription. Well, what did he do? He had United Healthcare. He called it in. He got on the phone, on the video with a pediatric urgent care center. He got his care. Yep, that's pink eye. That's good. We're going to call in a prescription. CVS delivered it to his door. The whole encounter, soup to nuts, 15 minutes. No loss of time at work. You think he's not going to use that again? Of course he is. So yeah, and it could be combined care. We've had stories even before COVID where we had complex care patients, even a pediatric patient who was on a ventilator at home and needed nutritional consultation, needed to see their regular doctor, needed to see their pulmonologist. In the past, that mom would have had to take a full day off from work, hire an ambulette, hire an aide to go with them, and one stop at a time. What happened with telehealth? We tried something out. We did what we called an interdisciplinary visit. We had 3 different specialties on the call at one time, and in one visit, virtually. Now, are there times when they're going to have to lay hands on somebody? Absolutely. You're not going to replace a face-to-face. But for those types of populations, we need to be able to consider that. And that was her choice to do that. And it made a world of difference. And it actually cost way less than what she would have had to have done, which would have been 3 separate visits, 3 different times getting in an ambulance. And even if it's covered by insurance, let's think for a minute, if I'm the insurance covering company, do I really want to pay for 3 times, create the inconvenience when I could have everything done in one time in one visit with everyone on one call? Even if they went to one provider and you brought the other 2 providers in, you'd still be ahead of the game, which is another workflow. We went back to that subject, right? Workflow. So the workflow connected with the visit and the level of efficiency of the visit is what's going to drive it, I believe.
Well, what is so poignant for me about those examples that you just gave, Iris, is as you're talking, I'm thinking about if there's any difference between those patients being in an urban setting versus a rural setting. So the examples both indicated the value of telehealth regardless if the doctor's office was 5 minutes away or 2 hours. So where we are up in Maine, and the large swath of our coverage area is rural, and the opposite is true for you, we're seeing these patients benefit from telehealth nearly the same, because there's a lot of reasons why, even if your doctor is 5 minutes down the road, whether it's you have kids to pack up in the car or you have a really complex care case that makes it difficult to travel.
Correct.
I think it really shows the value proposition of telehealth in all geographies.
That is actually really a good point. And one of the things that it was my mantra from the beginning, and again, this went back to before COVID, you can see that I was saying this well before that, and that is we need to change the mentality from rural to underserved. Period. Underserved. And underserved, you could be living with a doctor 5 minutes down the road, but if you're just barely making ends meet and you don't have paid time off from your job to go to a doctor, you're not going. You're underserved because you're restricted, or you're not going because it takes you 45 minutes to get downtown to a doctor when you're in New York City at rush hour. So I think that idea, I mean, there's certainly more at stake in some instances in rural areas simply because there's fewer and farther between. But underserved is really what we need to drive home, or convenience becomes important in terms of a decision as to treat now or wait and see if it gets better or not, which can be a huge elevation in the need of care simply because people are, in fairness, they're watching their dollars. And this is a period of time where we can use this data to make permanent decisions that will go well beyond COVID and not make it just a COVID thing, and we'll make it that permanent fixture. But for some, it had already become that. And I think, and because they're accustomed to it, that will continue from the millennials on. And for those prior, I think it's a lot going to depend on their coverage and their ability, as you mentioned, to get to a provider.
Well, so if we have our reimbursement doing what we need it to do to continue using telehealth, and we identify these patient populations that say, yes, this is the way I want to receive my care, and really let it be patient driven as you've described, I think the remaining piece of it is defining the quality and proving that the modality can deliver the same or even better clinical quality. In a 2019 interview, you had stated, I believe care and outcomes will improve as we become more efficient in our access and consumption of that care. Well, we now have the consumption. Do you think that we have the improvement in our clinical care and that vision of improved outcomes has been realized, or do we?
I think we're further along than we were. I think one of the things I'm really excited to see evolve is hospital at home. I think that's going to be a great model that will show all of the intricacies, because telehealth can't exist by itself. Remember, it's a tool. No different than when we introduced the stethoscope or anything. It is a way that we can expedite and improve care, but the models of care as a whole have to change, and they are changing. So, for example, at hospital home, think it has to be an interdisciplinary approach. And when you build with the technology, the hardware and the software to allow for that, you are going to be able to set up a more efficient system in many cases that will eliminate redundancy and improve efficiency. And I think that's really what we have to look at. And when you do that, it stands to reason you should improve outcomes. So we're going to need to probably look at our complex patient population, because those are our biggest utilizers of our healthcare dollars in this country, and apply these programs. And so a number of us, including Northwell, have been approved for the hospital at home program. That's going to incorporate telehealth with remote patient monitoring. And I don't necessarily think you can have one without the other. Mind you, okay, you can have remote patient monitoring and not have telehealth. They're different, but they can be integrated. You will have to have certain in-person services. So you have to look at where does it make sense? Where is that cutoff? And and I think that's going to teach us a lot with regard to hospital care and the change in hospital care. What I've said, and it remains still to be seen, but I think I'm starting to already see that trend, and you might be also, I'd love to know, Jasmine, if you're seeing this up there, is that patients coming to your hospital are going to be sicker and in more need of acute critical care. And COVID showed us we could do this, and are less intensely ill patients still in need of complex care could be cared for at home or in a lesser cost facility by the use of the technology that we have available.
Absolutely. We also had a telehealth-based program for our critical care and supporting our rural hospitals, but that translation can certainly be made to suggest that those lower acuity patients may have been able to be cared for at home. So I'm excited to see the outcome of the first couple of years of the hospital at home program. How do you measure clinical quality and efficiency at Northwell? How do you know that you're doing what you set out to do?
So, and everything has multiple influencers. So, it is very hard to call out exactly, especially in acute care. Let's say in the tele-ICU world, we know that tele-ICU, when we have a certain number of interventions by our EICU nurses, for example, that we improve outcomes there related to the intervention, to the timeliness, and we track back to whether somebody got worse or not. There's some pure data that we can pull out of that. You start looking out in the community, and there's some variables we can't control for. You have to be able to look at crosswalks and long-range data, and we're continuing to look at that. One of the first things is whether you even had a successful visit, right? Did the technology work to make that connection, to make that communication, or did it delay care? So that's a very simple first step to look at, because if they got the care they needed, great. If it meant that we wasted a period of time and then still had to schedule somebody to come in because the technology didn't work for them, then we've duplicated care. And that's one of the things we're looking at. And what is our failure rate, and who are our more successful utilizers of healthcare in our health system, of telehealth, and why? Is it the patient population? Is it the office support for the patient? Is it a particular specialty, and does that relate to that population of patient in their ability to get what they need in a telehealth care? And then we're trying to crosswalk the certain diagnoses with return to hospital or to emergency room. We have a community paramedics program, which is run, we work together. It's its own animal, if you will, under emergency services that is incorporating health solutions. And one day, I hope you'll hear from Dr. Zena Brown. They have a very successful program and a lot of great data, Karen Abashkin also, around the ability to level the number of times somebody comes to the emergency room by the use of a call center and telehealth in combination. So sometimes it's how you use it to avoid an unnecessary hospital transfer. But we have the capability to escalate, and we track how many of those cases did we have to escalate and why. And we're still learning from that data what is appropriate and what may not be. So it's still evolving, but it's very promising when it's used in the right population. We also know where it has failed.
That's fascinating. And I very much look forward to an opportunity to talk to Dr. Brown. We are also looking at opportunities for community paramedicine up here, as you can imagine, given the distance between our hospitals.
Yeah, so Dr. Brown does the health solution. So it's the physician and the nurse practitioner response. And then John Washko is also, he's helped to evolve that community paramedics program along with Dr. John Berkowitz. They're a fabulous team. And that's a really great subject to look at. It's a huge success.
That's incredible. I think that alone should be its own podcast.
It would be. It would absolutely be. John's done them before too. You'd enjoy it.
That's fantastic. Well, I want to just ask one last question before I let you go, Iris, is if you had unlimited resources and infinite buy-in, what service or technology would you implement or change to support the growth and advancement?
I mean, I would love to be able to give every patient their own endpoint to successfully be able to have a complete visit along with some peripherals, meaning some remote patient monitoring or synchronous and asynchronous tools that would feed data back to us that was the same in every patient home. Now, we know that's not happening. That's part of the struggle with remote patient monitoring being incorporated into telehealth to give us more information, so even less need to come into a doctor's office and continue to have a little bit more of a physical. And I know a lot of people are doing this. The ethics around what you provide and being able to give it to a patient and where the budget lies to be able to do that so that everyone uniformly has the same access to this same amount of monitoring would be something I'd like to see more universal as opposed to piecemeal.
That the ethics of telehealth utilization expansion would also make a good second follow-up.
For sure.
Well, I really appreciate your time today, Iris, and I hope that our audience found nuggets of wisdom. I certainly have that can help continue our great work across our own regions. Did you have any last comments that you'd like to make today?
No, I would just say biggest problem we have now besides education about how to use telehealth is really from an access standpoint is that digital divide we talked about, and we need to advocate for the populations that are impacted both in the rural and urban areas, or we will create a bigger digital divide, which will ultimately push us in the wrong direction. So advocacy, that's my biggest thing now. Really get involved. I never thought I would be, and here I am. So that's something out of nursing I never thought would evolve. And so we all can do it. If I can do it, anybody can do it. So the more the merrier.
Great point. Well, thanks again for your time today, Iris.
Thank you.